Welcome, everyone. We're gonna give folks a minute to get into the room. So yeah, quite a few folks coming in. We're probably gonna take like a minute and a half since the number keeps creeping up. So if you need to run and grab, coffee, water, tea, a cookie, it's Girl Scout cookie season. In a few more seconds, our attendee number keeps going up. We'll make sure folks have chance to all to all be able to listen. Hi, Millie. This is my cat, Millie. Anyone who has ever had a Zoom call with me knows she always shows up as soon as I start talking. I'm sure she will make another appearance at some point. Okay, we are 2 minutes after, and the number has seemed to slow down a little bit. Welcome to today's webinar. We are very excited. There she goes. We are very excited to have everyone with us today, and especially excited to have our speakers, Dr. Aaron Connors and Dr. Robert Gish, talk to us today about the new universal adult hepatitis B screening recommendations and what they mean for providers. For those who might have rolled in here not knowing what has happened recently, the CDC has released new recommendations around hepatitis B screening for adults, and what that shift means and how it will impact our ability to do our work is great and very positive. So we're excited to be able to learn more about how that work is going and what these recommendations mean. Seeing that this is a webinar, the attendees will be on mute, but the chat should be active. And so if you have questions, type them there or in the Q&A window. We will be able to capture those. We're going to go through both Dr. Connors and Dr. Gish's presentations and then come back and do Q&A all together. And we've left plenty of time for that. So please do be dropping in your questions throughout. And today's webinar is being hosted by the Hepatitis B Foundation. I'm part of that team. My name is Frank Hood. And it's also being hosted by a coalition that the foundation co-chairs, Hep B United, which is a coalition of more than 50 local and national organizations, really focused on reducing health disparities as it relates to hepatitis B. And we do that through trying to improve awareness, vaccination, screening, and linkage to care in the hardest at-risk communities. And we do that through a variety of capacity building programs. But each of those efforts around vaccination or linkage to care, really starts with screening. And so these recommendations are very relevant and then very important for reaching those communities. And we're clearly there's been quite a bit of excitement around hepatitis B, as there are 150 people attending today's webinar about screening recommendations. And over the last several weeks since these recommendations have come out, we've seen quite a bit of news, both news articles and stories, but also movement within programs and facilities across the country, really looking to incorporate these recommendations into their programming. And so I think that just shows that anyone who thinks that hepatitis B isn't important or relevant to the public health of today's society is wrong. And I'm hopeful that coming out of today, providers will be even more empowered to increase the screening and awareness in their practices, and that hopefully we can see a very robust and endemic approach to making sure hepatitis B is included in every step of the process, whether it's your annual physical or coming in for some other at-risk entity. So really excited to see how some of those pieces can kind of all tie together from our speakers. Lastly, wanted to say that this is the first part of a two-part series. We want to have a second webinar in the middle of April. We're like a day away from finalizing our final speaker for that webinar. We were hoping to have the date for today. But that webinar will be on what does the implementation of universal screening and vaccination look like. So really looking at programs that have done that sort of work already and are successful with it. So programs that are on today who might not be that far yet in their process are able to see an example of how that could work and potentially do it themselves. So our speakers, as I've mentioned, but I will show on this slide here, is Dr. Aaron Connors from the Division of Viral Hepatitis at the CDC, and Dr. Robert Gish, who has a million different hats, including here at the foundation. But we're actually going to start it with Dr. Connors, and she has some slides. So I'm going to stop sharing and let her share her slides. And I've been seeing it in the chat, but thank you. If you would like to introduce yourself in the chat, for any of you those on the webinar, please feel free to do so. Dr. Connors, I will turn it over to you.
All right, can you see my slides okay? And can you hear me?
Yes, we can.
Perfect, okay. So thanks everybody for inviting me today. I'm happy to give an overview of the CDC recommendations for hepatitis B screening and testing, and also a bit of how it integrates with the recent ACIP vaccination recommendations. So since I think most of you are familiar with hepatitis B, I'm just going to give a very high-level summary of sort of the background and impetus for these guidelines, kind of skip over some of the methods for the guideline development, and then really just spend most of my time on what is in the guidelines, how they connect to ACIP, and then end with a couple of hypothetical clinical scenarios to try to illustrate how the guidelines might be used in practice. So briefly, people with chronic hepatitis B virus infection are at increased risk for liver cancer and cirrhosis, and are 70 to 85% more likely to die prematurely than the general population. Based on NHANES, there are 880,000 people living with HBV infection in the United States. However, using a meta-analysis estimate, which may more accurately reflect the foreign-born population in the US, that figure may be as high as 2.4 million. And of those people, only about a third to a half are aware of their infection. So there's a huge opportunity to increase screening in the US. Previously, hepatitis B screening followed a risk-based approach. However, limitations of this approach can be seen in our surveillance data from CDC. From new data on acute cases that were reported, 2/3 of cases were either missing risk data or had no reported risk identified. So therefore, the new recommendation is screening is now recommended for all adults 18 years of age and up at least once in a lifetime. Also, screening continues to be recommended for all pregnant people during each pregnancy, preferably in the first trimester, regardless of vaccination status or history of testing. So this is not a new recommendation, it's a continuation from the 2008 guidelines. So during the initial screening, providers should test for surface antigen, antibody to hepatitis B surface antigen, and total antibody to hepatitis B core antigen. So the rationale behind recommending those 3 screening tests are it allows for a more complete clinical picture. So shown here is a table of all the combinations of results with the associated clinical interpretation and action. And this table can be found in the MMWR, as well as our website, as well as a lot of partner resources have a similar table. But overall, the 3 tests can allow a provider to establish whether the patient has acute or chronic infection, whether they had past resolved infection, if they show evidence of current immunity due to vaccination, whether they might be susceptible and need vaccination, or if they may need additional follow-up with a specialist or somebody who is knowledgeable about management of hepatitis B patients to help determine their status. So just a note, so in the guidelines, screening refers to testing asymptomatic people not known to be at increased risk, whereas testing specifically refers to testing people with either symptoms or who are at increased risk. So in addition to that one-time screen for adults, testing is recommended for everyone with a history of risk, regardless of age, if they might have been susceptible during the period of risk. And then additionally, ongoing periodic testing for susceptible people, regardless of age, with ongoing risk while that risk persists. When I say susceptible, what I mean is that includes people who have never been infected with HBV and either didn't receive a complete vaccine series or who are known vaccine non-responders. And then finally, anyone who requests hepatitis B testing should receive it, regardless of whether or not they disclose any risk, because we know that people may be reluctant to tell their doctor about risks that may be stigmatizing or embarrassing for them to share. Overall, this is just a summary of the rationale. A lot more of this evidence, again, is shown in the complete guidance document. But we felt that HBV infection has substantial morbidity and mortality. Chronic infection can be detected before the development of severe liver disease using reliable and inexpensive screening tests. Treatment for infection can reduce morbidity and mortality. Management of chronic infection might prevent transmission to others. Overall, we relied on a cost-effectiveness analysis, which found that universal screening
I lost audio. Can you all hear me now?
Yes, we can.
Okay, thank you. I don't know what happened. My phone hung up. Let's see. Some other reasons are screening enables identification and management of HBV infected persons who are pregnant, as well as their infants, which can reduce the risk for perinatal transmission. Screening can identify people who are at risk for reactivation if they become immunocompromised, and it might identify people who would benefit from vaccination. So as many of you are aware, in 2022, ACIP voted to recommend hepatitis B vaccination for adults 19 through 59 and adults 60 years of age and older with risk factors. They also recommended that adults 60 years of age and older without known risk factors may receive hepatitis vaccines. So overall, the intention is that providers can offer vaccination to all of their patients, including those 60 years of age and up without known risk factors. So the idealized process for integrating screening and vaccination would be that after the collection of blood for serologic testing, people who haven't completed a vaccine series should be offered vaccination for the ACIP guidelines at the same visit. It's not necessary to wait for the serologic testing results in order to administer the first vaccine dose. So while screening can identify unvaccinated people, it really shouldn't be a barrier to vaccination, especially in populations that are hard to retain in care or have low access to care. And if a patient declines either screening or vaccination, the providers can continue to offer at future visits. So I did want to stop and address this one question, which is we've received a lot from providers who work in settings where screening isn't possible. So as I just said that screening shouldn't be a barrier to vaccination. However, one-time screening with the triple panel should still be offered at future visits when a blood draw is available. Even after vaccination, we found that that one-time screen is cost-effective to be offering every adult at least once. And then one consideration is that transient surface antigen positivity can occur within about 30 days after vaccination. So if that screening is occurring, it should be after that 30 days after vaccination. Otherwise, there's a risk for false positivity. So here's a flow chart, which again is also in the MMWR and online. And it translates the recommendations into how a provider might approach screening, testing, and vaccination. So highlighted in blue is the new recommendation for all adults. If they've never been tested, we recommend screening with vaccination as needed per ACIP guidelines. So simpler than a risk-based approach. For those people that do have risk, we've expanded the list for those who'd be indicated for periodic testing to include people currently or formerly incarcerated, people with a history of an STI or multiple sex partners, or people with a history of Hep C infection. So once an adult has been screened, in future visits, a provider can assess whether additional testing is warranted based on vaccination status, timing of exposure in relation to previous testing, and then vaccine should be offered as indicated for those who are not completely vaccinated. For children under 18, only those who are not vaccinated as an infant per ACIP guidelines and who have risk exposure should be screened. I'd like to note a couple of clinical considerations. For susceptible people who are at risk for infection, the frequency of that periodic testing should be a shared decision based on an individual's risk factors and immune status. There wasn't sufficient evidence for us to make a recommendation about the ideal frequency of that periodic testing. Sort of similarly, for the new recommendation to offer testing for people with multiple sex partners, there was insufficient evidence to specify the exact number of partners and the time frame for screening in order to identify cases of chronic infection. So in other words, it was hard to place a value judgment of this with certainty of the relative risk of somebody with 2 partners over a 10-year period versus say 2 partners over a 1-year period. So therefore, it should be a conversation between the provider and the patient, considering the number of partners, the type of sex, whether or not it was protected, and the timing of the last test when considering to offer an additional test in the future. And then finally, providers can weigh individual potential clinical benefits of screening for patients who are 80 years of age and up. So I'd now like to walk you through 2 hypothetical clinical scenarios that hopefully illustrate how to apply both the screening, testing, and vaccination guidelines. So this is Charlie, who's 42 years old and has a history of injection drug use, but they don't report any current drug use. They don't remember if they've been vaccinated, and there's no evidence of either prior screening or vaccination in the medical record. So we can use the flow chart as a guide and follow the path. So it's unknown if Charlie's been vaccinated and they haven't been screened. And so both screening and vaccination is indicated. During this visit, the provider can draw blood for the triple panel prior to vaccination. At this particular visit, Charlie declined hepatitis B vaccination. Following up from the visit, we see that all 3 results from the triple panel were negative. So the interpretation is that they had no history of infection and are still susceptible to disease. So Charlie returned to care about a year later, still not reporting any drug use, but they did report 4 sexual partners. Now following the flow chart, we go down the path that they're still unvaccinated, but have been previously screened. So we look to see if they're at increased risk. Multiple sex partners is one of the risk factors for hepatitis B, and therefore periodic testing as well as vaccination should be recommended. Because the frequency and the frequency of testing and number of partners is a clinical consideration, the provider can discuss the potential risk. Because of reported inconsistent condom usage with the 4 partners over the past year, the provider used her clinical judgment to recommend testing. Now, I noted before that screening is with the triple panel, and that's a one-time screen for people who are not known to be at risk. However, there's greater flexibility when offering testing to a patient. So while the triple panel would still be appropriate, in this case, the provider decided to follow AASLD testing strategy, which is to test core. And then if that's positive, follow it up with the surface antigen and antibody tests if the core is positive. Just a reminder, total core is an indicator of either current or past infection. So from follow-up from the visit, we see the results were total core negative, showing no history of infection. Therefore, Charlie is still susceptible. So at future visits, providers can continue to consider testing based on any newly reported risk factors and continue to recommend hepatitis B vaccine. Next, I wanted to share an example for an adolescent. So May is 13 years old, and she immigrated from China 5 years ago. She did not receive a Hep B vaccine as an infant. However, when she moved to the US, she did receive a complete vaccine series before starting school. So using the children and adolescent flowchart, since vaccine wasn't completed as an infant, and there was the risk factor of coming from an area of increased prevalence, the provider should offer testing. And we can think about this as the rationale is that May was susceptible from birth to age 8, had a risk, and so therefore she should get tested to ensure she doesn't have a current or past infection. So the provider ordered the triple panel to screen. We can see from the results of the triple panel, results were all negative. The interpretation here is there's no history of infection. So one thing to note is she does have a documented complete Hep B series in her medical record. So we know that among vaccine responders who completed a vaccine series, you can see that antibodies do decline over time. However, the majority of people, especially those who are immunocompetent, are still immune to Hep B and will mount an immune response to a vaccine challenge. Data have shown that this persists for over 35 years after vaccination. And so in this case, we would still interpret that May would not be indicated for further vaccination because of that documented dose 3 series in her record. And just a note, because I know this is a question that often comes up, but these new screening and testing guidelines didn't reassess the guidance for who's indicated for booster doses. So we still rely on the 2018 and 2020 ACIP guidance, as well as other professional societies. So I'd like to share some other resources from our partners for more information about trainings, about serology, FAQs, information for patients. And this is from the University of Washington, WebMD, Hepatitis B Foundation, as well as immunize.org. And I'd like to acknowledge all the people, this is not exhaustive, of everybody who was involved in the development of these guidelines. Thank you, and I'd be happy to take questions after Dr. Gish.
Thank you very much, Dr. Connors. And just give me one moment to pull up or to share my screen.
Aaron, that was fantastic. And congratulations to you and your whole team for moving this forward and bringing it out. And the momentum, the attention here is just absolutely outstanding. The hepatitis elimination meeting that was in Los Angeles this last weekend, led by the led by ASLD with CDC and much other support. Our Canadian partners, our Mexican partners, was really outstanding. So Frank, let's go ahead and move forward one slide. So I really want to bring forward this message about hepatitis B we've had major problems in the past without having a clear message on vaccination, and the ACIP has really moved that very, very far forward. We've also been having challenges with hepatitis B because we had this risk-based screening, and now we have screen all adults. And we understand that risk-based screening has failed in HIV and hepatitis C, and we know it has failed in hepatitis B. And I'd like to highlight that over the last 20 plus years, in spite of having probably 20 or more editions of various guidelines and updates, the death rate from hepatitis B has not changed. We have obviously a problem in the US where we have a large population that's untested because of a variety of different barriers that exist. And we need to remove those barriers together for a couple of reasons. One is we have elimination goals by 2030, and we can't get to at least part of the elimination goals, such as reducing cirrhosis and liver cancer, without a test all approach. And I'll talk about treatment in just a moment. This is a heavy meeting about testing, but we're going to blend vaccination and treatment into this. I want to highlight that in previous editions, the issue about stigma and discrimination, especially in the guidelines, and I'll have to even self-criticize our own AASLD guidelines, where this was either minimized or not mentioned. I really want to compliment Aaron and the CDC team, where stigma figures in a prominent position inside the new statement, which is a major move forward. Also, quality of life has not been emphasized. We now have very large studies from Zubair Yunusi and others showing that hepatitis B affects people's quality of life, and with treatment, their quality of life gets better. It's also associated with extrahepatic diseases, including other types of cancer other than liver cancer. This is an infectious disease, and in the guidelines, most of the infectivity was talking about mother-to-child transmission. Really didn't talk about infectivity and reducing the virus, number one, by screening and testing and vaccination, and number two, by on-treatment reduction in viral load, which reduces infectivity. Of course, we're going to prevent the progression of chronic liver disease to cirrhosis, transplant, and death. So really think about these first 5 pillars as we're thinking about the hepatitis B world. And what I'm posting here today is open for comment. I'm crowdsourcing this directly, not under the auspices of Hepatitis B Foundation directly, but I'm planning to take this back with many comments I've received, about 100 comments to date so far, and take this back as we move to part 2 of the 5x5 message. Frank. All right, so, let's go back one. Here we go. So this is called the 5-line guideline. Well, not quite a poem yet, but getting close. And you've already heard about the test all for hepatitis B with a triple panel. And I really want to compliment also the CDC team for making super current the issue of core antibody. There's been a lot of pushback from various even colleagues that are, I think, frontline and in the know about core antibody. And one of the pushbacks is, well, it's work and it's confusing. Well, I'll mention that core antibody is not confusing. There is more work involved because you have to think through that one test at a different level, especially when somebody is core antibody positive only. But we really have information that dates back 20 years, even in low risk individuals, that the false positive rate for core antibody is 1 in 500. This is data submitted to the FDA by Abbott and Roche as they developed their 2nd generation core antibody test, which was very heavily involved in screening at the blood bank. And when people come to the blood bank, they're already low risk because they've been pre-screened with various questionnaires. So you've heard about vaccinating people who are triple panel negative, and the message that's buried here is that if somebody's core antibody positive, there's no data that has been published in the last 3 decades that boosting or vaccinating core antibody patients has any benefit except for maybe cosmetic by having a small change or forcing the presence of surface antibody. But there's no therapeutic benefit, and it's costly, and it gives the patient the impression that they're protected if they've been vaccinated, when actually the core antibody needs to trigger an assessment about occult hepatitis B potentially, and also about the risk of reactivation. We have over 70 medications that are immunosuppressive medications, and core antibody indicates when core antibody alone is present that there's a risk of reactivation. And of course, we save money by not vaccinating these patients and directing the vaccine to individuals who are at risk. So part 3 of this proposal is to link all surface antigen patients to HBV DNA, PCR, or what we call NAT testing, quantitative preferred, and also to Delta antibody screening, Delta antibody total. What's happened in the last 2 weeks is 2 new guidelines have come out. One's called the SABA guidelines, where Doug Dietrich's the lead author, and the other is the Chinese guidelines, where they're really moving to treat all patients. Now, in these guidelines, they talk about age 30 and either being DNA positive or DNA positive over 2000. But the simplicity of the Chinese guidelines and the simplicity of the new SABA guidelines are really, I think, a major move forward. I'm going to take it one more step with this proposal that we can simplify this and just say people who are DNA positive need to be started on some type of oral nuke therapy. Now, one of the pushbacks about these therapies is cost, but I think that cost should really be secondary to proposing the correct steps to respond to this triple panel after your vaccination step has taken place, and put people on therapy. And then we can start negotiating like we've done in the hepatitis C world for better pricing, reduced pricing, and bringing therapy to all these individuals. And really going back to the 5 pillars about stigma, discrimination, quality of life, infectivity. In the hepatitis C world, we treat everybody. HIV, we treat everybody. I think we have very clear evidence to move to treating all patients DNA positive for the 5 pillars that I described earlier. And of course, we need to stage patients and decide on HBV surveillance. You can see how powerful this new CDC guideline is about testing people and how we can build on that, but keep things also quite simple. I don't think we need 36 pages and 400 references to start working towards a world where we are working on hepatitis B elimination. And by 2030, even though we don't have a cure for hepatitis B, number one, we have a functional cure that's available in some patients. And number two, we can reduce liver cancer risk by over 70% by having full viral suppression. That's DNA negativity, even if patients remain surface antigen positive. Frank, let's move to slide 3, if that's okay. And I'm just about done, so we'll have plenty of time for Q&A because we know there's many people interested in this. I do want to make a major shout out to Sam So and Malika Toy with their modeling that was performed at Stanford. That was really a major step forward. So some key messaging when you're talking about hepatitis B. In the past, when we put people on TDF or TAF or entecavir, we had this message that it was forever or lifelong. And we really need to change that, that message. We have over 30 new hepatitis B drugs in development with 16 targets that I've reviewed recently. So I have great hope that we're going to be moving towards a functional cure rate that's in the 40 to 60% somewhere in the next 7 years. Don't hold me to the exact 7, it could be 5 to 10. And this means surface antigen loss and DNA negative in about half of patients with finite therapy. We're very happy that no one uses the word healthy carrier anymore, but we can, with treatment, improve quality of life. Yes, we need more research, but we shouldn't be using the term, we need more research to be a barrier. Often providers who I speak to, and I say we need more research, they say, well, you mean you don't know what's going on? You don't know how to advise. You need more research to make decisions. And we believe now as KOLs that we have plenty of data today to make these major steps forward. We have data to propose or advise vaccinating all adults. We have data to test all adults. And I believe that we have data now that we are going to be able to help patients along these 5 pillars by treating all patients who are HBV DNA positive. Now, the CDC publication, MMWR, is absolutely fantastic. What it contains, I agree with 100%. But there is one thing missing from this document, and that's Delta testing. We believe as KOLs, and I'm giving the word we to the great majority of providers that I talk to, and also the Hepatitis B Foundation, that if a patient is surface antigen positive, they should be checked for Delta testing, Delta antibody total, and that should be linked to Delta RNA testing. There are quantitative RNA assays out that are quite reliable. This is a 70% fatal disease in patients who have viral replication. And even if the prevalence rate's under 1%, by standard cost modeling, that is going to be cost effective to use a simple antibody test. So we really need to think about these 5-line guidelines to help our patients go towards the goal of elimination and bring patients into care. Many patients don't get tested because they think there's no treatment or no effective treatment or no cure. We need to give our patients hope that there's great steps moving forward. I think there's one more slide, Frank, so we can move to Q&A. I want to keep this short. So hepatitis B elimination will only occur when the human rights of all people with hepatitis B are respected. Testing and diagnosis must be to the sole benefit of the person being tested, but of course, this benefits society and this benefits the healthcare system as well. So I want to add that on. We need expert people, but we have so many expert primary care providers in the community, especially with webinars like this, that can take this very simple message forward. We can give people accurate and accessible information about their diagnosis, especially with this very simple messaging. And treatment services, testing of family members, and back to vaccination. This is really a full circle. And we have 2 new vaccines, Prehebrio from VBI, and of course, Heplisav-B are 2 enhanced hepatitis B vaccines. And Aaron did a fantastic job describing that these vaccines are effective. We have data in Alaska and data in Africa where people are protected out beyond 30 years. These vaccines are amazingly safe and extremely effective. And with that, I'll wrap up and turn it back to you, Frank, for the Q&A. Thank you so much.
Thank you. Excuse me. Thank you, Dr. Gish. I encourage attendees to continue to put in their questions into the Q&A. We have quite a few and a couple that we're going to actually turn over to Dr. Connors to start answering. So Dr. Connors, will screening be covered by insurance carriers?
Thanks. That's a question, probably the #1 question we get. So unfortunately, insurance plans are not required to make any coverage decisions based off of the CDC recommendation. Most coverage varies by plan type, and in the case of Medicaid, by state. However, there's one thing I should note is that after the passage of the ACA, most insurance plans do cover hepatitis B testing for adolescents and adults at increased risk. And that's what the recommendation that's set forth by the United States Preventative Services Task Force. And that's without any patient cost sharing. So I know the USPSTF is a separate body than CDC, and they may be considering an update to their recommendation to also move from risk-based to universal. I don't have a sense of when that would be. It would be over the next couple of years. But if they did make that move, then we would expect that most plans would cover it at that time. Otherwise, any other decisions to cover screening and testing is at the discretion of plan administrators.
Thank you. And I will just follow on to say that the Hepatitis B Foundation has been very interested and engaged in loudly encouraging the USPSTF to update their recommendations sooner rather than later. Because we do recognize the distinction of this recommendation being put forth versus the ability to actually lower that cost sharing for patients. So we're glad that we are part of the way there in getting these recs, but yes, there's still some steps to go. Dr. Connors, we had a question or a request for you to repeat the distinction between screening and testing.
Yeah, so, and this is sort of a nuance that is more evident when you actually read the guidelines. But when we say screening, it refers to testing asymptomatic people who are not known to be at increased risk. So you can think of this similar to when somebody reaches a certain age, they should be screened with a colonoscopy. The same thing, we're saying for all adults, they should be screened at least once in a lifetime, regardless if they have risk factors or, regardless of their history. When we talk about testing specifically, and usually in the context of periodic testing, that's for people with symptoms or who are at known increased risk. So everybody gets that screening at least once. Only people at risk or who have symptoms would get additional testing in the future.
Thank you for that. And I appreciate participants putting in their Q&A. We'll keep going through them. Dr. Gish, what is the best way to encourage primary care providers to screen and vaccinate for Hep B? We often hear that they're so overwhelmed and burdened with all of their other tasks.
Super good point, Frank. And there was a survey that was done at one point that said that if primary care providers did every advice, every flag, responded to every trigger in EMRs and all the different guidelines, they would be able to sleep 1 hour per day. So we need to prioritize this through education. I believe in the rule of sevens. And for providers, I think they're smart and it should be the rule of 5. They're going to have to hear this 5 times with all these different 5 points. So it's kind of the 5 rule to carry this forward. But I think that it's relatively simple. And I think that with good marketing and good education, we will get to this next level.
Thank you for that. And I will also, in the chat, I am dropping in the Hepatitis B Foundation's call to action around eliminating hepatitis B through vaccination and screening implementation. We will be on our the second webinar of this series, be diving into this far more. I will be hearing from the person who helped put this together, Michaela Jackson. This was a labor of love, and she was the point on it. As well as some of those examples from providers, as I mentioned earlier. So thank you for that, Dr. Gish, and we have some resources right here for folks who are interested. Looking back through the Q&A, there is a specific question around occult hepatitis B. How would this present and what do the lab results look like for that?
Fantastic question. When they've surveyed individuals who are core antibody positive only and checked 100 patients, let's say as an example, for hepatitis B DNA by PCR, this is not standard because it's usually surface antigen links to PCR testing, we find between 7 and 15% have low levels of HBV DNA. I really want to compliment the CDC and many departments of health around the United States because they define hepatitis B now as being either surface antigen positive or DNA positive. So this is a very important distinction because if somebody is DNA positive, such as the core positive patient I mentioned, and they're surface antigen negative, they're still defined as having chronic hepatitis B in most cases. And then the implication of this DNA positivity goes to 2 directions. One, if we're going to treat everybody that's DNA positive, we would have that discussion with the patients if we carry that fact forward. And also these individuals may be at higher risk for liver cancer. And of course, they're more infectious because they're DNA positive. So OBI, occult hepatitis B, has its own little silo of education that we need to bring forward. It is relatively simple. PCR testing goes down to about 10 international units per ml. That's 10 viruses per ml. It's quite sensitive. And there is a good threshold there for infectivity risk, increased cancer risk, reactivation risk, and consideration for treatment.
Thank you for that. Dr. Connors, question for you. Do you recommend continued Hep B screening in each pregnancy for those with documented Hep B immunity?
Yes, so that was the continuation of the existing recommendation. So a pregnant person should get screened for surface antigen during every pregnancy, regardless of their vaccination status, immunity, or history of testing. And some of the rationale behind that is that it's really important to have in the record linked with that pregnancy so that we can ensure that the infant follow-up that needs to happen occurs. So it's more of a conservative approach, but one that we feel, this is old guidelines. I think the consensus is it's such an important opportunity to prevent perinatal transmission that we need to have a heightened sense of screening in those populations.
Thank you for that. Dr. Gish, if all surface antigen positive are treated, do you have concerns about suboptimal treatment with lamivudine, where TAFT and TDF are better agents aren't available?
It's a great question, because really in the review that I went through, you wouldn't treat every surface antigen positive patients. It would just be surface antigen plus DNA. And this person is correct. Lamivudine is really non-advised. It's not recommended as therapy. And lamivudine, adefovir, and telbivudine, I described, should be in the museum, the medical museums, and should not be used in the US or globally. We really have access to TAF, TDF, or entecavir, I believe, in almost every country. And those medications, depending on the country and depending on pricing, has different price points. Lamivudine, anybody that's on lamivudine should be switched to one of our first-line therapies, specifically a TDF or TAF, not entecavir. And people should not be on adefovir or telbivudine, although those medications are not widely available to date. And finally, clevudine is available in Korea and in the Philippines. It's a very old medication with a long history. In my opinion, those patients should be on first-line therapy as well.
Thank you very much. We have a lot here. What do you see as some of the biggest barriers to initiating treatment for those who are surface antigen positive but don't meet the AASLD criteria for treatment? Those in the sort of the gray area.
The biggest barrier are the guidelines. And this is what's interesting. We speak to different people, including Dr. Locke, who help write the guidelines, and I really compliment them on their detail and level of evidence and quality of evidence. But what is not really apparent to the people who write the guidelines is the insurance companies like to use the guidelines to deny care. And they become a barrier. The guidelines in among themselves, their complexity, the gray zone, or insurance companies, the guidelines become a barrier to accessing therapy. So I think the guidelines need to be sensitive to this fact, as well as the discrimination, stigma, and quality of life. And the guidelines need to be simplified. Fortunately, today, AASLD has formed a committee to rewrite their guidelines. I met with, in Taipei, the APASL leadership and pushed them very hard to rewrite their guidelines. And EASL is also rewriting their guidelines. So I had a call yesterday with Pietro Lampertico. I had a meeting in Taipei, and I asked these leaders to harmonize the guidelines so we look globally and have a consistent message, because people will point to one guideline or the other if they're thinking about not treating or some reason to escape this treatment pathway. Let's harmonize, let's simplify, let's have hepatitis B catch up with hepatitis C and HIV. And we have a vaccine preventable disease. There's no vaccine for HIV or hepatitis C. So this vaccine message needs to be prominent and put forward in parallel with these incredibly important testing recommendations. Hopefully that's not too long of an answer.
No, and actually we had received a question that I was thinking of going to next, and then you said what you just said. So conversations around screening and immunization are very separated right now. How do we get the two groups to push this messaging together so communities are not confused? I would love to hear from both of you if you are able.
Erin, you want to go first?
Sure. So I think some of that reason that it's separate is because there was such a lag between the vaccine and the screening, just due to different processes and different timing. But now that they're both out, I think we can go. I know at least CDC is making every effort to have all our materials join the two of them together. Of course, Hepatitis B Foundation, Hep B United, and other folks. Hopefully, professional societies will also start developing materials that really bring the two of them together. I think there will be some gaps in what CDC is able to advise in terms of harmonizing the two, because they are two separate guidelines. So we're really looking to our partners to identify any challenges and offer some solutions and recommendations for how a provider should approach the two.
I really think this harmonization will take place globally. I left out one of the most important organizations, which is the WHO, and Saeed Hamid, one of my close friends and colleagues in Pakistan, is on that WHO committee, and they're rewriting their guidelines currently. And they're often quite sensitive to differences in access to, say, nucleic acid testing. In some countries, getting a PCR is more expensive than a year's supply of hepatitis B. Homi Razavi, who's leading these global modeling projects, been in Uzbekistan, where they're treating everybody who's surface antigen positive, because again, testing is more expensive than the medication. And these types of outputs are going to help us think about where we can apply that. We'll still be doing some customization. We're talking about simplifying. There still will be some issues about test access, test costs, and in some countries, medication costs can be high. I work in Vietnam a lot, and the hepatitis B cost per year is in the $1,000 range, whereas you can get it for $50 a year in many countries in Africa and other countries around the world. So we really need to scale cost of medications to local economics so we can get this treatment to everybody.
Thank you for that. We have a question around talking about the screening guidelines in pregnancy and vaccination guides, screening guidelines in pregnancy and vaccination guides, prioritizing fetus and infant over potentially pregnant persons, and a request for leaders to push for a new standard that vaccinates susceptible postpartum persons on the same vaccine schedule as infants. And was just curious if either of you had thoughts on how we could make sure to better cover the health of both children and their parents.
Yeah, I can speak to that a little bit. I mean, the data definitely show that there's a drop off, especially for pregnant people who are surface antigen positive. Even if they receive that diagnosis during pregnancy, they don't necessarily receive the follow-up care that's indicated after they're no longer pregnant. And so that's definitely a gap that needs to be improved, especially among DNA positive women, or pregnant people, making sure that they get on treatment. I know that the American College for Obstetricians and Gynecologists, or ACOG, and the Society of Maternal Fetal Medicine are reevaluating their hepatitis recommendations in light of these new vaccination and screening guidelines. And so I'm hopeful that they may be emphasizing the importance of vaccination during pregnancy, since Hep B vaccination during pregnancy is safe and effective. Want to add anything to that?
Yeah, I want to give a shout out to Calvin Pan and the work that he's done in China, and also the publication from Thailand by one of our great French colleagues who's been working in Chiang Mai, Dr. Jourdain, that if you give the vaccine within 2 hours of birth, we may not need HBIG. That's an amazing extraction I got from that New England Journal of Medicine. And also, there is data coming forward that if we treat at a little bit lower threshold in pregnancy, instead of 200,000 IUs at 20,000 IUs, this is some data that hopefully will emerge from Calvin shortly in his work with his Chinese colleagues, is that again, we may not need HBIG. And HBIG is expensive in some countries. It's out-of-pocket expense. In many countries, it could be in the $50 to $200 range. It'd be nice to get rid of HBIG. We'd get rid of one whole step in that process. There is operational challenges of giving vaccine within 2 hours of birth. I guess I'm a little idealistic. I'm saying, well, if you give it in 6, why can't you give it in 2? But we have a great news on the cold chain that these vaccines are stable at warm room temperature for up to 30 days. So the cold chain issue with the vaccine is much less of a problem, a minimal problem now. So let's get this message out globally, and we can prevent mother-to-child transmission. In the United States, we have 1,200 babies born each year that are surface antigen positive long-term. So we're not carrying the torch fully in our wealthy country.
Thank you for that. What do you, this for both of you, and then after this, we have there's been a couple of questions about testing wanted to get to. So what do you think the best message to convince people that don't think they are at risk to get screened and vaccinated?
Either. You want to go first?
Okay, I'll go first on this one. So we take the risk out of the equation. Since we're not using the word risk anymore, then the patient won't come back with a question about the at-risk statement. And we just say, we need to go, there's many exposures that people have they don't know about. There's blood exposure in different environments. And we just say, there's exposure risk just by being alive. Let's just get tested. It's a very simple blood draw, and we're not taking a risk history. I think one thing that's been emphasized very well in the CDC document, as well as other places, is that risk history taking is often stigmatizing. As much as we think we're sensitive providers, this can be insensitive even in the most sensitive hands. So let's take that out of the equation, although it's still necessary for surveillance, as Dr. Connors has been great to emphasize. But let's get the first step done. You do vaccine at that time, you do your test draw, and then suddenly as you develop a relationship with the patient, you can take that risk history and then build that into your surveillance strategy.
That's great. I don't have much to add, except I can put in some links in the chat from CDC website that are about vaccine hesitancy specifically, and especially some lessons learned from COVID, as well as measles and other vaccination, of how to increase confidence in vaccination.
So we had several comments around point of care, and with the note of that it could be difficult to get phlebotomy to those at risk. So what are the thoughts or impacts of moving to have a point of care screening, either triple panel or something like a dried blood spot for surface antigen? Dr. Gish, you want to talk about that impact in your setting?
So point of care testing is a really hot topic and something I'm working on every day. So we have one challenge. The FDA has given hepatitis B a class 3 designation, which means they have to fill something called a PMA, a pre-market authorization step, which costs a company $380,000 to apply, and they're acting like it's a new test. If they go to class 2, like hepatitis C and HIV, it's called a 510K. I don't expect anybody to remember the numbers or letters, but it's a $10,000 application. It becomes an equivalency test. My interpretation is, and there's a little controversy here, it's much cheaper to have a 510K and the barrier is low. And I am working with a company who has a rapid test that we published. We have data in Thailand. It's beautiful. It's a triple panel, hepatitis B surface antigen, C antibody, and either HIV or syphilis. And we're working on a cassette, a lateral flow with a triple panel with all the hepatitis B tests. But we have a barrier of how much it's going to cost to develop this and keep the tests cheap and inexpensive and cost effective. But we can get there. And if you all are advocates in this world, let's keep some advice or pressure on the FDA to move from class 3 to class 2.
And I'll just add, because I know this was also a question you had brought up at AASLD, Dr. Gish, but CDC has put forward a letter of support to the FDA recommending to move to class 2 as well.
We still have a minute. Okay, well, how do vaccine non-responders fit into the update?
Yeah, so generally they fit in a couple different ways, and I think it's most obvious with the adolescent population, as well as the adults, that we're just offering this broad screening, and then for people who are at risk among the adolescents, in order to pick up people who might have been vaccine non-responders. I think it's a little more complicated in terms of what to do with the next steps in terms of boosters, and that's one area where we defer to ACIP, and I think we do need to get clear on the guidelines for what specifically to do if an antibody comes back negative and there's a concern that it's due to non-response versus just a normal waning antibody. I don't know if Dr. Gish, you have recommendations from practice that you usually follow. I know there's some guidance for primary care providers from the work group.
I think the data from Senegal, the data from Alaska, 30 plus years, these people are protected long-term, even if they have senescence of their surface antibody. I think if people we have documentation of 3 doses of the 3-dose vaccines or 2 doses of the 2-dose vaccine. They don't need to be checked. They don't need to be boosted. There's a tiny bit of a controversy here. I debate Mark Sulkowski about the HIV patients and boosting that are, I think, in the ACTG guidelines, if I have the right source correctly. There's no data there that vaccine boosting helps anybody or that it decreases new infections. So we really should be evidence-based. We've been shooting from the hip sometimes with this when we don't have data. And I think now let's focus on testing people and vaccinating people and not spend time and money on checking antibodies and boosting. I don't think we have data that has a clinical or patient benefit.
Awesome. Well, thank you both very much, Dr. Connors, and thank you very much to the more than 150 participants of today's webinar. We have recorded it. We hope to have that recording up and out actually by tomorrow, because we understand there were folks who were going to miss today, and they were very much like, is it going to be recorded? So yes, it is. We're going to get that out. We will also make sure to follow up with everyone who registered today as soon as our part 2 webinar is locked in. We appreciate the robust discussion and conversations, and continue to please reach out to the Hepatitis B Foundation and the Hep B United to help so we can help support you and your local coalitions on the work that they're doing every day. And please don't hesitate to fill out the post-webinar survey. So thank you once again to our panelists, and everyone have a great rest of your day.